So, good afternoon. The session will be over the creation and arteriovenous fistulas using VasQ external support. And today we have three speakers, well-known speakers. What we do this afternoon is that we will have the speakers give their presentations, and at the end of the three presentations we will have a panel discussion. So the first speaker is Andrea Rumuzzi, professor from Bergamo. And the title of his presentation is What Happens After Fistula Surgery? Start the video, please.
This presentation was made by Professor Andrea Rumuzzi from the University of Bergamo, who has received a research grant from Lemonade Medical.
Thank you for having me here today. In this presentation, I will analyze the vascular changes that develop after AVF creation and some preliminary results we have obtained in a longitudinal study aimed at investigating geometric and hemodynamic changes that take place after fistula surgery. After the arteriovenous surgery, we want fistula to adapt to the arterialized flow by development of robust walls able to handle frequent needle punctures. We know that fistula have a high rate of primary failure, mostly due to stenosis of the just anastomotic segment. The stenosis develops as an adaptive response to unsteady flow that leads to inward remodeling of the vein. The factors that are associated with the fistula remodeling and then failure are the following. First, changes in the geometrical configuration post-surgery. Secondly, the increased wall tension. And as a third factor, oscillatory wall shear stress acting on the endothelial cells. As shown in this slide, instability due to high flow rate of blood and sudden geometrical changes may lead to vessel stenosis. We have learned from vein bypass graft that mobilization of the vein comprises the wall structure of the vessel and leads to thickening and stiffening during remodeling. Vein mobilization implies removing the vein from its natural support. This vessel manipulation removes the vasa vasorum that feeds the cells within the vein wall. As shown in this diagram, changes in the vein wall over the first 4 weeks include important endothelial damage, vein arterialization as a consequence of wall tension and hypertrophic remodeling, with smooth muscle migration and proliferation and growth of the new intimal layer. We have demonstrated that after AVF surgery, blood flow instability develops in the venous segment of the anastomosis. This induces oscillatory shear stresses acting on the endothelial cells. These stresses induce endothelial cell dysfunction and a pro-inflammatory state, likely inducing abnormal vessel remodeling. In order to mitigate geometrical changes of the vein vessel and the flow instability, an external mechanical support, the VasQ, was designed to provide a mechanical constraint to vessel remodeling. The VasQ is placed around the artery and the vein at the anastomosis to taper geometry of the venous segment. The VasQ reinforces the structure of the vessel wall against increased wall tension. You can see in this angiogram of an AVF treated with the VasQ at 3 months, the taper transition of the vessel geometry. There are other examples of the effect of external support on vein remodeling after arteriovenous bypasses. As you can see in the left image, hypertrophy of the vein wall develops with time in this vessel, with the formation of new intimal layer and reduction of lumen diameter. With an external support using the vein graft bypass procedures, the impact of the structural reinforcement on hypertrophic remodeling is mitigated. These IVUS images from 2 separate coronary artery segments in the same patient show that more meningeal hyperplasia occurred without structural support, as compared to structural supported vessels that reduce the wall tension and reduce the hypertrophic response. This study had not been done in the AVF, but similar principles likely apply to dissected vein and mobilized vessel in the just anastomotic regions of the AVF. We and others have previously reported that non-physiological flow conditions develop in the venous side of the anastomotic area due to the important increased blood flow and the sudden increase in venous cross-sectional area. This resulting flow instability and the oscillating wall shear stress acting on the endothelial cells might predispose to neointimal hyperplasia later in time during vessel remodeling, and this will lead to vessel stenosis. In order to prevent excessive vessel remodeling near the fistula anastomosis, an optimal anastomosis angle and a taper geometry should be obtained, and this can be done by an external support, by regularizing the blood flow and reducing the area of the flow instability acting on the endothelial cells. The aim of our study was then to investigate geometrical and flow dynamic changes that develop in an AVF after surgery in individual patients treated or not treated with the VasQ device. We used a non-contrast enhanced MRI protocol to generate three-dimensional models of vessel lumen geometry at a 3-day and 1 month after the surgery. The numerical model was then used to analyze blood flow field by solution of the Navier-Stokes equation with boundary conditions obtained by ultrasound for the estimation of the inlet and outlet blood flow rate. Then a post-processing analysis was adopted to obtain a visual representation of flow streamlines, as shown in this animation. The preliminary results that follow have been obtained from this pair of patients that have similar vessel sizes and anastomosis angle at the baseline. The patient-specific theoretical analysis of the flow field showed major changes in velocity distribution passing from 3-day to 1 month after surgery, with important increase in flow instability in the venous outflow tract. On the contrary, in the AVF treated with the external device, the flow is more stable and it is aligned along the main flow direction. These flow patterns are the results of important geometrical changes in untreated AVF, while the VasQ device prevented such changes. The difference in the flow patterns is shown in these animations that represents one complete cardiac cycle. We also calculated the oscillatory shear index along the vessel luminal surface, that is a measure of the fluctuation of the shear stress forces acting on the endothelial cells. In the untreated AVF, at 1 month after surgery, large areas in the venous outflow tract have been estimated with potential activation of the endothelial cells. On the contrary, in the treated AVF, shear stress oscillations are limited to smaller focal areas with preservation of the endothelial cell function. In conclusion, the evidence I provided indicate that just anastomotic flow instability may be associated with the stenotic remodeling and be the cause of AVF failure. We have demonstrated that an external support has the potential to structurally reinforce the vein and to promote more stable geometrical and hemodynamic conditions. Our preliminary results from a longitudinal MRI-based analysis suggest that the VasQ device may prevent geometrical changes post-surgery that are associated with suboptimal hemodynamics and possibly to development of neointimal hyperplasia. Let me just finish thanking the contribution of my collaborators to this work, especially from the University of Bergamo, from the Mario Negri Institute and from the Bergamo Hospital, and in particular to Michela Bozzetto.
Thank you very much, Dr. Rumuzzi, for this very nice presentation and study. So we will have the discussion afterwards. The next speaker is Robert Shahverdyan from Hamburg, with the title The Who, Where and How of VasQ Implantation. Start the video, please.
This presentation was made by Dr. Robert Shahverdyan from the Vascular Access Center at the Asklepios Clinic in Hamburg and has no conflict of interest.
My name is Robert Shahverdyan, and I'm a vascular surgeon and a head of Vascular Access Center in Hamburg, Germany. I was one of the first surgeons to adopt VasQ external support device as a standard of care, and before showing you the recorded case, I would like to introduce you to the technique and patient selection. Now, the VasQ is indicated for a subcutaneous AV fistula creation with support at any location, provided the vein is at least 2 mm and the artery is at least 2 mm, but not more than 6 mm big. And the VasQ can be implanted for a radiocephalic fistula and also for an ulnar basilic fistula creation at the forearm, and also as a brachiocephalic or brachiobasilic fistula at an upper arm. Here are some examples of VasQ implantation for radiocephalic, brachiocephalic fistula and brachiobasilic single-stage basilic vein transposition AV fistula. Now, first of all, I would like to thank Dr. Matteo Tozzi from Italy for providing us with his recorded case presentation. Now, let's start with a case presentation. Here, typically dissection of the, in this case, brachial artery and cephalic vein. Here is the upper arm cephalic vein in a cubital fossa. We have already dissected the vein and now looking for the brachial artery in typical manner, dissection of the tissue, searching for the brachial artery. So nothing spectacular. You do it the way you do it. It was a cross-clamping of the vein, dissecting the vein. We typically do hydrostatic dilation using heparinized silane. Now here is the model selection tool. This is the newer version which will be soon available. That is why there is an animation of that selection tool. It has 6 different sizes. And to choose the right size of the VasQ device, it is advised to first try it on the artery so it fits without compressing it, but also without having much space between those. Now in this case, it would have been size 2. Now after heparinized solution is administered to the vein, we should identify now the size of the selection tool for the vein, and then in this case this would be number 3, for example, and number 4 is too big for the vein. So basically, if you have a bigger size for the vein than for the artery, you select the larger of the two, or vice versa. Now back to the cephalic vein. Creating the anastomosis should be in a typical manner. We don't advise to create a bigger anastomosis with a brachial artery than 3 or 4 millimeters. Then, using a small mosquito clamp, you introduce the VasQ device on the vein. Of course, this is just a schematic view, so you don't need 5 meters of vein to be dissected. You just put, as shown here, the VasQ device upon your mosquito clamp or forceps, and then put it around the cephalic vein. And it is very easy to leave it there by using a small Baldock clamp, so it's not disturbing you during the creation of the anastomosis. And after doing it a couple of times, you get used to it, and you don't actually need much longer distance for the dissected vein in order to keep the device away from your anastomosis. So typically, it is our tradition to administer 2000 units of heparin before clamping the artery. It might be different in different practices. In our practice, it is always the case. And then measuring the length of the vein, creating the suitable size, arteriotomy, and then in a typical manner creating the anastomosis between the artery and the vein. Now this is the technique which is typical for your practice. You don't have to change it. It should be done as you're doing it all the time, and the VasQ device is barely visible. You just kind of hide it under the skin flap, and then it's not on your way. And basically, in typical manner, you create your anastomosis. So after a couple of cases, you will get used to the fact that the VasQ device is not disturbing your suture. At the beginning, typically you think it will be uncomfortable, and then it's also important to measure the length of the vein so it's not overly long or overly short. This is basically possible just doing it before advancing the VasQ around the vein and then clamping it, and then after creating the anastomosis, flushing it, we just remove the clamps and we have the VasQ device in its position. And now what we're using is a B-flow with an ultrasound where you can see the typical, let's say, black spots in the area of the higher turbulences, and it kind of confirms the computational models which were used for the creation of the VasQ device. And now the eyelets are fixed with a typically 5-0 prolane around the artery. We recommend to clamp the artery, the inflow artery, before pulling down the VasQ device, so there is not so much pressure in the vein and it's not disturbing that. And then after the device is in its position, you give the flow free, and then we have the B flow again, where we see the VasQ device here in the image, and now you can see that laminar flow around the juxta-anastomotic vein, and also when you follow the vein cranially, it is also with a nicely B flow, nicely filled out B flow in the vein, and then close the incision in the routine manner. And then again this schematic model where you can see that using the VasQ device you would have the more uniform flow in the juxta-anastomotic region, as it would not be in case of a not supported vein typically. So that would be the video of our case. Now our experience in Hamburg with VasQ device was published in the Journal of Vascular Access a while ago already, and we have compared our results with 33 radiocephalic AV fistula using VasQ devices, and the AV fistula, radiocephalic AV fistula, we have created before VasQ has become standard of care, and we have demonstrated lower primary failure and also less interventions and higher significant primary patency rates and secondary patency rates for the VasQ device in a radiocephalic setting. Now, to conclude our experience and also the available experience that most AVF creation locations and anatomy are eligible for the VasQ external support device, its implementation is simple and it adds very little time to the procedure, and it's not uncomfortable at all. And more of my AVFs actually became usable with less interventions when I adapted VasQ as my standard of care in our Vascular Access Center in Hamburg. Thank you very much.
Thank you very much, Dr. Shahverdyan. Very nice presentation. So we proceed with the third speaker. This is Alexandros Mallios from Paris. And the title is A Review of Current and Future Data for VasQ. Start the video, please.
This presentation was made by Dr. Alexandros Mallios from the Paris Saint-Joseph and Chartres Hospital, who is a consultant for Laminate Medical.
The organizers of the meeting and Laminate Medical for the invitation to present about this very exciting new technology. We have heard from Dr. Rumuzzi the mechanism of potential action of VasQ, and then by Dr. Shahverdyan about technical tips and tricks and how he uses VasQ in his practice. And now I'm going to dive a bit into the data and the results about AVF that we have so far from the worldwide application of this technology. I agree that arteriovenous fistula is the gold standard of vascular access for patients that need hemodialysis. However, it's a widespread knowledge that results of standard AVF creation are often disappointing. And we know from the most recent prominent studies about AVF that the results of primary patency are rather disappointing, with 47 to 66% of primary patency, which essentially translate in 1 out of 2 patients needing some form of dilatation in order to achieve maturation. The experience with AVF from the studies that VasQ was used was, however, very encouraging, with primary patency rates at 6 months ranging from 77 to 88%. Rates of the fistula creation, of the fistula created, again, the standard AEF fistula for almost 2,000 patients ranged the usability of this fistula between 40 and 66%, while for patients that the VasQ was used, for almost 200 patients, the usability of the fistula was almost for every patient achieved with a range from 86 to 100%. After prospective and retrospective and generally collected data, what everyone wants to see is randomized control trials, and that was achieved and published by Dr. Koridis at the American Journal of Kidney Disease with a randomized control trial with high quality data coming from 3 centers in the United Kingdom and 1 center in Israel. These were brachiocephalic fistula. The patients were randomized with a 1-to-1 ratio, and we had 20 patients at the VasQ group with 20 patients at the control group, with a follow-up going to 1, 3, and 6 months. Primary endpoints being the safety and usability of this fistula, the maturation at 3 months, and secondary endpoints, the primary and secondary patency at 6 months. The results of this trial came to confirm what we had seen in the previous slides and the previous accumulated clinical data, with a significant difference regarding the freedom from stenosis, significant more than 50%. You can see here at the Kaplan-Meier the blue line representing VasQ and the red line representing standard AVF, and you can see that the standard AVF was more or less what we have seen in previous studies, and the VasQ again consistent with a significant difference, the p-value at 0.4. This translated to different patency outcomes, with a primary patency that was superior for VasQ and secondary patency that was superior for VasQ. Again, of course, as we know, the stenosis does not always translate to intervention, hence the not exactly same difference in percentages that you see between the degree of stenosis and the patency outcomes. Regarding fistula usability, the results from the same study, you see that in 3 months 90% of fistula were being used, and only 10% of the patients remained on catheter. 45% of fistula, standard fistula, being used, and 55% being on catheter. At 6 months, a statistically significant difference, with 100% of the fistula being used for VasQ group and 56% of fistula being used for the standard group. Regarding the factors associated with usability, there was a multivariate logistic regression analysis that showed that the use of the device was predicting with a very high odds ratio success regarding usability, and of course the evolution of vein diameter per 1 millimeter of difference was also significant in terms of predicting the usability or not of the fistula. Analysis of the effect of the use or not of VasQ in terms of the evolution of vein diameter for these patients, and you can see here on the left side the control group starting at the same median diameter of veins as compared to the VasQ group, and you see a much more consistent evolution of the vein diameter, which is of course related with the success or not of the AVF creation, as compared to the control group, that you see a much more chaotic evolution of vein diameters, with some of these veins actually going down in diameter, which of course is related with the failure of maturation for this fistula. The ongoing prospective studies for VasQ external support in the United States, there is a pivotal trial with 144 patients randomized in many centers and very experienced colleagues of the United States. The enrollment was completed on February 4th with a 6-month primary patency and safety endpoint and a 2-year study period. In Europe, we had a great experience with the device. We were also part of this study, and I'm very happy to see actually the results with our own hands and our own eyes, and see indeed under ultrasound that these fistula do look different. Especially we did just radiocephalic fistula in our center, and at the shrink point you can really appreciate that the evolution of this AVF is different as compared to standard fistula that we didn't use device. The endpoint in Europe was a 6-month primary patent safety point. This is a worldwide growing experience with more than 1,000 patients having received the device, and a very consistent I would say level of results all across the board from the many centers, experienced centers and colleagues that have used the device, with 35 active centers in Germany and very good reimbursement code. As we know, Germany is usually much faster than other countries. 15 active centers in Italy, and many countries awaiting reimbursement. Actually, in Europe, France being the case, which is we're waiting eagerly in order to be able to start using the device more widely, and the breakthrough device designation by the FDA for the United States. The vascular external support device produces a consistent clinical outcome across many studies and many different practices, with a consistent high primary patency in multiple studies, a significantly reduced incidence of stenosis, and consistently improved AVF usability, and of course, which translates to a reduced need for a central venous catheter.
Thank you very much, Dr. Mallios, for this nice presentation. So the panel discussion is now open. Probably I can start off. I'd like to question to Professor Rumuzzi. And of course, I know the work that Professor Rumuzzi is doing in his institute, and we work together in the past years. And so my question is a little bit how the VasQ really works, because we know there's a lot debate about the angle of anastomosis. And maybe if you have a very acute angle, it gives more oscillatory stress as a more a 60-degree angle. That's one of the things. The other thing is that how can you get better hemodynamics if you prevent the outward remodeling? But usually we need outward remodeling to have maturation. And with this device, you just said the outward remodeling is fixed in the first centimeters of the vein, and after that you should get outward remodeling because of you need a diameter increase for using the fistula. So my question to Dr. Rumuzzi is, what is the most important thing, the fixed angle of the device or the ability to prevent the outward remodeling by the device?
Good afternoon, everyone. I'm pleased to answer this question because this is a complex situation, as you know, regarding the hemodynamics. And these two factors, to me, are playing together. The fact that the VasQ is able to maintain the anastomosis angle is good for a better hemodynamic condition exactly at the anastomosis site. Then the shape of the vessel is tapered by the VasQ support. So this allows the flow to enlarge the cross-sectional area, but gradually. And this means that the flow instability is not developing so immediately as without the VasQ device. And of course, after the mechanical support, if you are going along the vein, then the vein will be able to dilate and to remodel outwarding. So this means that is the combination of the fixed angle and the fact that the shape is tapered that has a good and a favorable effect on preventing flow instabilities and random distribution of the shear stress, and especially the oscillation of the shear stress that we expect when the flow is very unstable.
Another question also for Dr. Rumuzzi is, the device is on a certain distance on the vein, and I just heard from you the device is tapering the vein from a small diameter to a large diameter. But you can imagine that there is some transition zone where the external device ends and the vein is uncovered. So you could expect that you get just in that area problems with oscillatory stress, because the vein is going to remodel there outwards, and it is fixed more distally. And maybe it could be also an area that you can expect to have more disturbance in flow and probably also development of intima hyplasia and stenosis. What is your opinion about that?
Well, actually, what happened is that since these taper geometries allow to increase the cross-sectional area of about 1.5 or 2 in a ratio between the initial area and the end area of the device, then this has a very big effect on the flow velocity. So the flow velocity can be almost alpha of the flow velocity that there is near the anastomosis. This makes the instability of the flow less important. And more than that, the shear stress is not so high. And the shear stress can not challenge too much the endothelial cells and then the vascular remodeling. So I think that the geometry of the vessel is designed in such a way that the hemodynamic is optimized. And it is optimized inside of the tapered geometry of the VasQ device, but also in the following part, because in the following part, the vessel dimensions are in such a way that the velocity are not so high as at the anastomosis.
Okay, thank you very much.
Thank you.
A question to Dr. Shahverdyan. So you have done patients with, I expect, radiocephalic fistulas and also brachiocephalic fistulas in your population. So my question is, which inclusion criteria do you use to see if the patient is eligible to put in this device? And are there special patients that are probably more eligible, have more benefit to use this device compared to other patients?
Yes, thank you, and good evening, everyone. Well, in my experience, we have done much more radiocephalic AV fistula than brachiocephalic. We have done a couple of brachiocephalic, some brachiobasilic, and we also had a couple of cases of Gratz fistula where we had the opportunity to use the device, and also did a ulnar basilic fistula using the device. So we have a broad spectrum of using the device. And since we're not part of any study since the beginning, and I've started using the device 3 years ago, we wanted to exclude as many as possible biased patients. So we have started to use the device in all patients who were going to get the AV fistula, whether it was radiocephalic or the rest of those, because we didn't want to select them because the vessels were bigger, because they were non-diabetic, because the artery was nicer, because the gender was better, or the age was younger. We started to implant it in every patient and excluded since that only one patient at the beginning, because at the time I was not sure whether I can use the device because the vessels were too close to each other, and I was afraid that the device would push away the vein. But since then we have used it also in this setting because of the experience. And that was the only patient where we excluded that. Otherwise, only the patients with pre-existing big vein, which is bigger than 6 millimeters, and the device will not fit on it. So we are using it in every patient. So we're not selecting them.
Okay. And another question is, did you have patients that had an infection and you needed to remove the device?
From more than 150 cases we have used the device, we have never seen any infection. We have never required to remove the device in none of them.
Okay. If you have a problem with a flow decline or a thrombosis, with a stenosis in the area of the device, how can you treat that?
We are using a balloon angioplasty in almost every case. And sometimes we use the transradial access nowadays more often, retrograde transradial access from the wrist. So we're able to treat the artery also if it has some problems. and the balloon angioplasty is possible or was possible in all those cases. You cannot expect to use a bigger balloon and then get a result that if you put a 6 millimeter balloon in 3.5 millimeter VasQ device where the ring is, which connects the brace with the braid, that it will go up to 6 millimeters. But we typically use a 5 times 20 millimeter balloon. And in most of the cases, we had significant increase of the flow. So it is possible to use it endovascularly. We have done a couple of patch plastics, I think 2 or so, but those are, as I said, more than 150 cases we have experience with.
How I don't understand that patchplasty in the area of the device. How can you do that? Because it's metal.
You can do it. Yeah, you can cut it with a
you can cut the metal.
Yeah, you can cut through it. Yeah.
And you put in a vein patch or a graft prosthetic patch.
We don't use prosthetic patches, either vein patch or if it's not available, we use a pericardium.
Incredible, good.
And if you look at the device some time later, you can see the scar. You can see a pseudo-adventitia also around it. So it's really grown into the tissues, and you can cut it with a soft scissors at the ventral wall and use the patch plastic. Okay. But it was like 2 or 3 cases.
Perfect. And last question for you is: if you have a patient with very thin skin and a very superficial vein, is this a contraindication for the VasQ device?
We haven't excluded those patients, and none of those had any feeling regarding to the device, no pain, no discomfort. You can feel it through the skin, but we haven't seen any problems with that.
And no risk for compression, outside compression?
No risk for compression.
Also, also not in the elbow region if you bend your elbow. It's not a problem.
Well, we haven't used it exactly in the elbow. We have used it for Gratz fistula at the proximal forearm. So due to the length of the device, it wasn't compressed by an elbow movement. Okay. So we haven't seen any problems.
Okay, thank you very much. So, question for Dr. Mallios. So, in this randomized study, I think the number to treat is reasonably low. So, is it possible to draw any conclusions of such a small study? That's one of my questions. Was there any preoperative ultrasound performed in these patients to see if they were eligible to include in the study?
Thanks, Jan. Good question, and I also had the same thoughts about this study. But the data is what it is, and for some of the data, the number was sufficient to provide a statistically significant result. But I'm not sure that we were able to answer all of the questions or provide an answer for every individual category of patients, or generalize that the VasQ device is applicable for every patient. For sure, we need more data, but more data are about to come shortly.
Okay, thank you. I think also what is very interesting to know where the stenosis were located in the vascular access. Were they located in the area of the device, or more proximally in the vein?
I'm not sure that these data are available in the study about the exact location. However, my short experience was that the part of the fistula that device was used was more free than the fistulas that device was not used. So there seems to be an immediate effect of the device at the exact location that is being placed.
Okay. And probably I didn't hear, I just misunderstand it, but how many, in this randomized study, how many radiocephalic and how many elbow fistulas were included in both groups? I couldn't figure it out from your slides.
It was about half and half.
So in both groups?
Yes.
So that was comparable in both groups, the location of the vascular access?
Absolutely.
Okay. Are there any questions from the participants? Yes, please.
For me, the main question is not is the VasQ device a good device or not a good device? It is a good device. That's no question. The modulation of the flow and the modulation of the shape of the vein is a very good concept. And the very sympathetic concept of the VasQ is to treat a complication of the shunt, of the fistula, before it occurs. But the problem is not all of the patients with the first vascular access develop stenosis, type 1 stenosis. So the main question for me is, for whom is it the perfect device? Exactly which patient is it a good device? Because I want to treat the patients with a high risk of development of a type 1 stenosis. Not all the patients.
To whom like you address this question?
To Robert.
Shahverdyan.
Yeah.
Dr. Shahverdyan, what's your answer on that?
Well, my first answer would be a question to an answer. From those AV fistula you create, can you prognose which would have a juxtaanastomotic stenosis?
No.
And that would be the first
problem.
So if you cannot prognose whether it's 30%, whether it's 20%, or whether it's 40%, whatever your numbers are, whatever the numbers in the literature are, you don't know which ones would develop it. So therefore, there is no formal to select the patients for the device, in my opinion. That is why I use it in all of them, because for me, if the failure would be 20%, let's say, and I use the device and it's 15%, 14%, or 10%, then 5% or 10% of the patients who might have failed will gain from the device. And that's the only way I can use the advantage of the device. Otherwise, I don't have another answer to that question.
Okay.
Thank you.
Are there other questions from the participants? Okay. Thank you very much for all the speakers for the excellent talks. And with this, I close the session for today. Goodbye and good afternoon.
Thank you.
Thank you.